I hand over to Kate to...
Or would you like me to continue?
Well, it's really just hosting some more questions now on any of the topics you've heard about today.
So it can be any of the subjects that you've heard about or subjects that we haven't covered.
Hi, I've recently been diagnosed with problems with my thyroid and underactive thyroid. My GP says that it's due to the imatinib. Is this correct?
So it's difficult to say exactly. There have been some reports of both lower thyroid and also thyroid inflammation on all of the TKIs. Some of the TKIs have caused a quite destructive pattern to the thyroid, so that's quite clear. We usually tend to involve the endocrinologists in these discussions, but from the aspect of treating hypothyroidism, it's quite simple. It's just whether there are some other immune type complications that would go with it. But many patients don't have their thyroid function affected, so it's difficult to say in isolation.
When do you anticipate the license for asciminib will be forthcoming? Crudely.
3 years.
So probably at least 3 years. It's not in a phase 3 trial yet, or the bosutinib one, but I'm not sure that's going to be enough patients.
There's still quite a few patients, but it seems to be very well tolerated because it works in a different binding site. It doesn't have those off-target side effects, but it hasn't been a panacea for every patient. Some patients still have had side effects on asciminib.
And they're still looking at different dosing schedules and whether or not to combine it with other drugs. So it may take them a little bit of time to work out exactly where to place it.
Okay, thanks.
I think it's far from clear, actually, whether they'll seek a full license for asciminib, because you could say, well, hang on a minute, you've got 5 drugs already available in CML, and for most patients, that's more than enough. So we're really just thinking about patients who aren't doing so well on all 5. So it may be that they're going to seek quite a limited license, and this is all undecided, and I suppose commercially sensitive as to what the sales are. But I think at the moment, I don't think any of us are too worried about accessing asciminib for patients who really will need it at the moment with the, it's called compassionate use scheme, and in due course for people who really need it, who have failed all the other drugs. But whether it's going to be taking over as a first-line treatment, so fast forward to these meetings in 10 years' time, we'll be talking about asciminib as the standard of care. Somehow I doubt that. Yeah.
Afternoon, my name's Andy Steer. I was diagnosed with CML in 2018, and thanks to you guys and imatinib, my CML seems to be doing nicely. One thing I do suffer from occasionally, and it can be on a hot day, is very icy cold hands, and occasionally I'll have my thumb or fingers just lock up. I'm just looking for any advice I can be given to try and lessen this effect.
So I did the side effect talk. So you may have something called Raynaud's syndrome, where your hands go white, then dusky red, and then are painful, or you just have your hands going white. So sometimes, again, there can be an immune complication with that, or so that needs investigating separately. The locking, it could be a cramp. I don't know if because some patients have unusual cramp in their jaw and their back, places that you would never expect to have a cramp. If you're doing fantastically on your imatinib and your response is very deep, the license dose to start off with is 400, but there may be some room for manoeuvre to drop that to 300, which is also a licensed dose.
Okay, thank you. I'm currently on 400.
So the cramps.
Yeah, we found calcium and vitamin D very helpful for cramps. Even if people's levels are biochemically normal on the tests, having an additional calcium and vitamin D supplement, many of our patients have found very helpful.
Do you have a job or a hobby where you're using vibrating tools or driving a lot or anything like that?
I'm an admin, so most of my days keyboard,
Typing.
and my hobby is photography.
Okay,
So
no.
there's no, yeah, click, click, click.
Because sometimes people can get these symptoms if they, say, a lorry driver or somebody that's working with vibrating machinery a lot, you can get these hand symptoms. It doesn't sound like it's that.
So back to the cramp, because usually we look, every time you come to clinic, you have a blood test, and that includes your potassium, your calcium, sometimes your magnesium. And if patients do have muscle pain or cramp, then we tend to correct these. But cramp itself, we tried calcium and vitamin D and magnesium. It wasn't so effective. And then plus patients had to take a whole load of other tablets 3 times a day, so they weren't very happy with that. And quinine, so the FDA, which is the American licensing, have actually cautioned against quinine for cramp, but on the NHS helpline, we still recommend it, which is a age-old therapy for cramp.
Okay, well, I think somebody in the room today actually suggested maybe using or eating more bananas. Would that
It increases
possibly
your
help?
potassium. Could do.
That's very healthy.
Okay, well,
Good
thanks
for
for
the
your,
digestive system, but
yeah.
but only the horrendous tasting dark one. Not
No,
the
no
light-
cheap brands.
No.
That's right.
Well, thanks for your advice, but the other thing I'd like to share is a group that helps to tackle mental health, and it's called Andy's Man Club, which some of you may or may not have heard of. But in brief, it was set up just over 3 years ago, and it tackles people to talk about anxiety, depression, suicidal thoughts. There's currently 22 groups in the UK. You can find out more information at andysmanclub.co.uk. And last night, they won the ITV Awards for Diversity. So and it's meet on a Monday night, 7 while 9, totally non-judgmental, confidential, but it really helps. Sadly, for ladies, it's only at the moment for guys. But I'm sure guys generally don't talk much, do they? So
I've heard of something similar called the Men in Sheds Club, which has broadly similar aims for, again, only for men, I'm afraid. But so, yes, these things may be of use. Yeah, absolutely.
well, thank you for your time. And the awards last night were in your hometown of Liverpool.
Oh, right, okay.
Afternoon. I was just wondering, has anybody done a whole life cost of an optimum transplant versus a lifetime of TKI? And what did it come out at?
Well,
So-
yes, I was just going to say I'm certain NICE have done this, and that, as James just said, transplants are cheaper for the economy. Though I'm not sure if that would have taken into account the fact that imatinib is more likely to have people at work for longer and therefore paying taxes. I'm not sure if that was taken into account. Because people are going to be off work for longer with a transplant proportionally. But, yeah, money isn't everything, is it?
Right, yes. Thank you.
Hi, I just want to ask, if a patient's already failed one therapy, how likely will they be to fail treatment-free remission?
It's a good question, and I wish I could give you a good answer. And the reason I'm struggling a bit is that the vast majority of the studies would have not allowed people that you describe onto the trial. Having said that, I'm just thinking that there must be a couple of studies of patients who go onto imatinib and then fail the imatinib. Now, if by fail you mean had a rash or an unpleasant side effect and then had to switch to another drug.
No, I mean losing.
Right, but if you did mean that, then the answer is probably it makes no difference. As long as people get onto a good remission with their subsequent drug, it may not matter. But for people who are truly resistant, failed because of resistance, there's less information. Overall, the results are not quite as good as if people hadn't failed their first drug. But I wouldn't want to put anyone off consulting locally if they have, for example, had imatinib, not had a good response, and then switched to dasatinib, bosutinib, nilotinib, and then had a good response, which would have got them to those low levels that I talked about, that would have meant that people could go in otherwise. I would be a bit more cautious about the chances of success, but I wouldn't say, no, for goodness sake, don't do that. Where I would say don't do that is the group of patients that I did briefly mention who've gone into blast crisis to advanced phase, and then even if they've gone back to a very good place with subsequent treatment, possibly with a transplant as well, I would be very cautious about recommending stopping treatment in those patients, unless there were particular circumstances which would apply to individual cases. Yeah.
So, there's the DADI study, and then there's
Yes, there's DADI
STOP,
and there's
second generation French study.
That's right.
You know, and I think the treatment-free remission rates go down to 10% in some of those studies. So
I don't think they're quite that bad, or you
DADI,
may be right. The 30 to 40% was what I was remembering from the French one.
yeah.
Well, the intolerant patients do almost as well as others. Yeah, you're right. Yeah, you're right. The minority were resistant.
We're not meant to stop anyone with a mutation, so that's usually resistant patients with a mutation. However, we have just published a series of our patients who needed to stop because of quite severe complications. So they had a mutation, were resistant, and stopped. And in fact, some of those patients, including T315I patients, have had quite a durable, ongoing, deep molecular response. But these are very extreme circumstances where you wouldn't routinely try and do that. So it all depends on monitoring and the risk of progression.
It's a question about nilotinib, and it's taken every 12 hours. It's a fantastic drug, but it can be quite inconvenient at times. How strictly do you have to stick to the 12 hours? Is there any leeway in that? And also, how strict is the fasting period that goes with it, from 2 hours before to 1 hour after taking the drug?
I think the manufacturers would say, obviously, that's the optimum way to get the best results. In our experience, it depends a little bit on the circumstances. If you've already obtained a very good response from your drug, then, and you potentially might be somebody who would think about de-escalating or reducing the dose anyway, then we've started to be a bit more relaxed certainly about the 12-hour gap. Perhaps not necessarily so much about the fasting. But I think in the people that have started to tweak it and make changes, we've not seen any dents in their response. You obviously need to be monitored if you're going to make any changes.
It's more on a sort of a one-off basis here and there, where, I don't know, you've got a set routine and you might be going out for a meal, say, or whatever, that falls right in between.
I would say if you're in a good response, I wouldn't be too concerned about that.
What I wouldn't do is I don't know whether you're on 300 twice a day or 400 twice a day, but
It's actually just 200.
200 twice a day. What I wouldn't do is to say, oh, well, it's kind of inconvenient, I'll take all 400 at once. Now, actually, 400 once a day is probably fine. Well, certainly fine, because many patients are on 400 twice a day. But if someone in the room or on the TV is on 400 twice a day, what they mustn't do, or even 300 twice a day, what they mustn't do is to say, right, it doesn't suit my lifestyle, I'll take all 600 at once or all 800 at once. Because we know, at least from lab studies, that results in quite a peak level, which is really potentially quite toxic. And we looked at this on behalf of Muslim patients who find it difficult in the summer months to observe Ramadan and not take anything during daylight. And it's probably not wise to do exactly what I've just described on the safety grounds. And if you're forced to do that by life circumstances and so on, is just to miss a dose now and then.
So there's also a French study called the Myeloid study, where they looked retrospectively at patients who were on a reduced dose of nilotinib, and the majority of these patients were on 400 to 450 milligrams once a day, and responses were maintained in those patients. So rather than taking a split dose, they were taking it once a day. But they already had good responses.
Okay, thank you.
Two questions, if I may, completely different. As Dragonor might remember, I was on dasatinib for 3 years with very good response and no problems and no side effects, and then suddenly I had a reaction to it and had to stop. I just wonder whether that is something that has been observed more widely or whether I'm unique.
No, well, obviously you're unique, but as in my talk, these side effects can happen at any time. So even if you've been fantastic for many, many years, you can still get a pleural effusion, some sort of side effect. We were caught out at the beginning when we had imatinib for the first time. I thought, can't possibly have a rash 8 months down the line, but sadly, no, you can suddenly develop a side effect even many years down the line.
Thank you. Yes, that's very helpful. Thank you. The other question was, as someone who has been living with TKI withdrawal syndrome for a couple of years, I wondered if any research is being done into that or whether it's just seen as an inconvenience that people are just going to have to learn to live with.
No and no, I think. So there's very little going on this. It's all descriptive, and the reason there's not much description either is that this was unexpected. So it takes ages to set a trial up, and then it takes ages to run a trial, and it takes ages to analyse the results. So Destiny ran from 2013 to 15 recruiting, and the first report of this problem was Christmas 2014, was it? I think. So we were well into the trial, and so was Euroski. And what we would have liked to have done is get a much better picture of people's musculoskeletal health, let's say, and history at trial entry. So if one was designing a Destiny's Child study or something, a follow-on study, then you definitely want to try and include that to answer exactly what you've just said. And that, but still would be only descriptive. What I think we can say is that there's no hint that this is some form of inflammatory joint disease that's going to be more serious, like rheumatoid arthritis, which can cause joint destruction. There's really no hint of that in any of the patients in anyone's study that have been referred to expert joint people. And what was your last question? Is this something that people's got to live with? Well, you haven't got to live with it because it does seem in the very few patients that have actually gone back on treatment because they're so fed up that the symptoms improve quite rapidly when back on treatment. But for most people, of course, you've gone through all this pain of giving up and tolerating unpleasant symptoms with withdrawal. Why on earth would you want to jack it all in and go back? But for some patients, that's the only answer. And it does seem to work for the limited number of people I know about.
So I've had a slightly different experience to that with the TKI withdrawal. So I've had 2 patients who have had quite severe TKI withdrawal and have, of their own volition, restarted their TKI and their symptoms didn't get better. I've also had a couple of patients who I have referred to rheumatology and have had an underlying joint condition. And I think the TKI, because it has an anti-inflammatory effect in itself, and as we were discussing in the last session, can be used to treat graft versus host disease because it has this anti-inflammatory effect. It can sometimes, when you stop it, unmask an underlying condition. And it might be worth, if it is persistent, maybe having it looked into a little bit more, especially if it's been going on for over a year, because usually it should be getting better within sort of 7 to 10 months.
I think it is very, very gradually getting better, but it still hasn't gone after 2.5 years.
I think there's association historically for radiation exposure, so following atomic bomb and industrial radiation disasters. I think there's otherwise not a lot of ongoing knowledge about other factors lifestyle-wise that bring it on. So I don't know about active research. There's epidemiological studies going on all the time into all the cancers, a very active unit in York here that look at all the new cases and gather epidemiology, meaning characteristics of the population and what are the factors that could be triggering it. But I'm not aware of anything new.
Shall I go for it? Right. I was diagnosed 25 years ago, this December, coming December, and I went on to imatinib in, I think it was 2003. So, and I'm doing well, I'm fit, and I'm 74. So, and I'm just starting to think maybe I should go for the trying not coming off imatinib, because I've been on for quite a while. Do you think it's a good idea?
Do you think it's a good idea? Because it's your decision. It's not a decision if, like appendicitis, where you really got to have it out tonight, otherwise things are going to go very badly, but if you have it out, things are going to go very well. It's not a decision like that. It's very much a decision for individuals. And obviously none of us know your detailed PCR results, but let's assume they're all negative for donkey's years or something. It's still your decision.
What about halving the dose?
There's all sorts of ways of doing it, but I think the question of whether to do it or not is your decision. And if you're keen to do it and you're in a unit that's got some experience, that's actually very important. If you're in a unit that's got some experience at coming off treatment or supervising patients at coming off treatment, then it may be perfectly okay. And Dragon is just prompting me there. There will be differences if you ask everybody around the country, but I think what I've done for quite a lot of patients now since Destiny closed is to follow the Destiny protocol. So to have a rehearsal by going on to half-dose treatment and seeing how you get on. So as I showed you, it's quite, assuming your disease is very well controlled, it's highly unlikely that anything adverse will happen, but you might feel an awful lot better. On the other hand, you might feel exactly the same and thinking, well, I'll just stay on half-dose, and, you know, those are decisions for once you get going sort of thing.
I do always counsel patients that it depends a little bit on where their mind is at the time, and there's a definite impact of moving from a situation where just having your PCR result has started to become a bit more routine, that you result after result after result is looking good and your head is perhaps in a more relaxed place. And it's very different to go into a situation where you're suddenly on monthly monitoring and suddenly every result matters again. And there is the possibility that it won't work out. And there is psychological and emotional impact of that. And that can be a timing issue of whether the other aspects of your life are in a good place to add that on top. And that aspect of it isn't for everybody. And I include that in talking to people about whether it's right for them and whether it's the right time for them.
The other thing to think about is if you're somebody perhaps travels a lot and you stop and then it comes back and you have to change your dose of treatment, then you would have to inform your insurance company. So you might have to pay an extra premium on your insurance, even though your leukemia has not truly come back, because your treatment dose has changed. You would have to inform your insurance company for travelling, and some people, on the basis of things like that, might decide not to stop.
So I think we've got time just for one last question.
I was diagnosed about 13 years ago, and one of the things that, or the symptoms I had before I was diagnosed, was real deep aching in my thighs. And it was like this incessant ache that never went away. But being on the TKIs, one of the things that you get that you attribute to being a side effect is the aching in your thighs. So how much of it is actually side effect, and is there actually damage from the original disease that still hangs around? How do you put it down to, what do you put down to being the disease, and
it's
what do you put down to the drug?
Know, isn't it? Yeah.
The disease is what your PCR is showing you, but if the PCR is good and the CML level is low, then it's unlikely to be the CML itself.
So there's no residual damage from the original?
So I would say
I've
no
not
residual
seen
damage because of the CML. Sometimes patients have very high white cell counts and platelet counts at the beginning and have some bleeds at the back of the eye. But apart from that, for your general muscles and bones, from the CML, no. From the actual drugs themselves, there are some very rare reports about affecting the bones, but not the muscles. So if you have these symptoms still, it might be worthwhile just getting checked out by your GP.
Tried that.
Or checked out by your haematologist.
Don't listen. No, listen. Thanks.
So just a few closing remarks. We've talked about the different options that we're lucky enough to have now for CML, and very much it can be about finding the right fit for you. It may be that the first drug that you're on is not the ultimate one that succeeds, but overall it's about finding the right fit, and knowing now that outcomes are very good for leukemia control, our consideration of your side effects and your other illnesses become ever more important. So is CML all sorted? Well, some of my colleagues in oncology would say, well, it's a bit like this. You guys have got it easy. You've got such a big target. But we know that's not entirely true, and there's still unmet need in CML. We all still see some cases that simply don't respond to the medication, and if people do transform, it remains very hard to treat. Side effects remain very significant for some people. And we've also talked about the changes in the generic imatinib supply being frequent and unpredictable. So we do continue to need better treatments that are more potent and better tolerated. And the scientific research underlying the new drugs remains absolutely essential for our further progress and for further understanding how treatment-free remission works. And we heard from Jane earlier about the global inequality in CML outcomes. And I think that's certainly worth highlighting. So your voice in all of this remains vital. We've heard about the research study upon research study that has got us to where we are now, and funding is getting tighter, and it's important that we do keep CML on the radar, that it still requires funding for ongoing research. CML networking we've been doing here today and across the country with the webcasting, and there is a CML family worldwide. Jane spoke about the International CML Foundation that's very much looking to improve care across the world, and the climb for a cure in Mount Kilimanjaro. So we need to continue to aim high to improve outcomes and work towards an operational cure for the majority of CML patients, not just the minority. So it's very important that I finish off with a lot of thank yous, and I hope you join me in thanking our speakers, all our speakers today, for giving up their time. We need to thank the Royal Armouries, our fantastic AV squad at the back there, who've had a long, long day and have helped us enormously with all our IT glitches. Very grateful to our pharmaceutical sponsors, Bristol Myers Squibb, Pfizer and Incyte. Thanks to Mari, Angela and her team at the University of Glasgow for the administrative and organisational support, Sandy and David at CML support, Marsha from the Tai Chi Tigers, and above all, it's been an extremely interactive day. Really enjoyed it. Thank you very much to all of you and your families and carers. Thank you. The meeting is closed.
And can everyone just say thank you to Kate as well for organising it here on the ground, because I hope you'll all agree it's been a great day. Thank you, Kate.